A total knee replacement is supposed to be life-changing, right? It's all about restoring mobility and kicking that chronic pain to the curb. But what happens when, after a seemingly perfect surgery, the knee just refuses to bend? This is the incredibly frustrating problem of arthropibrosis, or what's commonly known as a stiff knee. So let's dive into this common but often really misunderstood complication. First things first, let's get some perspective on this. Here in the United States, we're talking about over 1 million total knee replacements, or TTAs, every single year. And for the most part, it's one of the biggest success stories in modern medicine. Over 80% of patients are thrilled with the result. But it's not a perfect story for everyone. For a pretty significant group, we're talking up to 13% of patients, the outcome isn't what they were hoping for at all. They end up developing this debilitating condition called arthropibrosis, which can lead to pain, major functional problems, and sometimes, even more surgery. So what is arthropibrosis exactly? Well, you can think of it as your body's healing process going into complete overdrive. Instead of creating a normal, flexible scar, the body just goes wild, building up all this excessive, thick scar tissue that basically gums up the new joint. And that's what restricts its movement and causes that awful stiffness. Okay, so here's our game plan for this explainer. We're going to cover the whole journey of the stiff knee. We'll kick things off by figuring out why it happens and who's at risk. Then we'll walk through the first-line treatments and see what happens when those don't cut it. And we'll finish up on a really hopeful note, looking at new ways we might be able to prevent this from happening in the first place. All right, first up, why does this even happen? I mean, what is it that triggers this super aggressive scarring response in some people, but not in others? Here's a really great way to think about it. Imagine a normal healing process is like a construction crew. They come in, they fix the damage, they clean up, and then they go home. Simple. But with arthropibrosis, that crew never leaves. They just stay on site, endlessly building and building, laying down more and more internal scaffolding until the joint is practically cemented in place. So what's the actual scientific name for this rogue construction crew? Well, they're called myofibroblasts. These are the specific cells that produce collagen, which is the main building block of scar tissue. And in arthropibrosis, a signaling protein called TGF-beta basically gets stuck in the on position, telling these cells to just keep pumping out collagen relentlessly. And what's so important here is that doctors can often spot patients who are at a higher risk, even before the surgery. A huge predictor is having limited range of motion to begin with. Other red flags can be things like previous knee surgeries, certain autoimmune conditions, or even just a genetic tendency to form thicker scars, like keloids. Okay, so let's say it happens. You've got a stiff knee. What's the first line of defense? Let's take a look at the initial steps doctors take to try and break up that scar tissue and get things moving again. The treatment approach is like a ladder, and you always start on the first rung. That means aggressive, really targeted physical therapy. The whole goal is to mechanically stretch and break down those early scar tissue adhesions. If that's not getting the job done, the next step up is a procedure called manipulation under anesthesia, or MUA. This is where a surgeon, while the patient is asleep, physically forces the knee through its full range of motion, literally breaking up the scar tissue. But here's the catch with an MUA. Timing is everything. It works best when it's done within the first 3 months after the original surgery. You have to get in there before that scar tissue has a chance to fully mature and basically turn into concrete. And the numbers, they really tell the story here. A big review of the data showed that patients who had an MUA within that 3-month window gained, on average, 32 degrees of flexion. That's a lot. But if they waited longer, that gain dropped to just 19 degrees. That is a massive difference, and it really drives home why acting early is so critical. But what if MUA isn't enough to solve the problem? Or what if the stiffness just gets diagnosed too late? Well, that's when you have to move on to the more advanced surgical options for these really stubborn cases. So when MUA fails, surgeons have to climb higher up that surgical ladder. The next step is usually an arthroscopic lysis of adhesions. It's a keyhole surgery where they go in with tiny instruments and just physically cut out the scar tissue. If that's still not enough, they might have to do an open arthrolysis, which is a much bigger, more extensive clean-out operation. And the absolute last resort? A full revision TKA, where they take out the entire implant and put in a new one. But as you climb that ladder, the risks go up too. And this chart shows a perfect example of that trade-off. See, the infection rate for a simple MUA is super low, only about 0.5%. But look what happens when you move to an arthroscopic procedure. That risk jumps almost 8 times higher to 3.8%. It's pretty simple. More intervention means more risk. This flowchart really ties everything we've talked about together. It's like a visual roadmap for doctors. You can see the logic they follow. Over on the left, they first have to rule out other causes of pain. If it's truly arthrofibrosis, they start with things like physical therapy. If you follow that no improvement path, you see the next step is MUA. But notice that's really only an option within about 6 months. After that window, the path leads directly to those more intensive surgeries we just discussed. It's a really clear step-by-step approach to a very complex problem. So up to this point, we've only been talking about treatment. But let's be honest, the holy grail here isn't treatment, it's prevention. What if we could stop this whole crazy scarring process before it even has a chance to start? And this brings us to a really fascinating landmark study that came out of the Mayo Clinic. The researchers asked a really simple but powerful question. Could common everyday oral medications, I'm talking about things many of us already have in our homes, actually have properties that could protect against getting a stiff knee? And this chart shows the key data from that study. It's showing something called odds ratios, but don't worry about the term. All you really need to know is that any value below 1.0 suggests the medication might actually protect against stiffness. Now, they looked at a few different drugs, but let's just focus on the 2 that had the most dramatic results. First up, patients who took common non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, around the time of their surgery had 33% lower odds of developing arthrofibrosis. That is a really significant reduction from a simple, often over-the-counter class of medication. But this next one, this one is even more incredible. Patients who took oral corticosteroids had a staggering 74% lower odds of needing that manipulation procedure later on. This is a huge deal. It suggests that if you can powerfully shut down that initial inflammation right after surgery, you might be able to prevent severe stiffness altogether. It could be a total game changer. And the research doesn't just stop there. Scientists are looking at all sorts of other promising ideas. Things like using a common blood pressure medicine called losartan for its anti-scarring effects, developing these special scaffolds that release anti-inflammatory medicine right inside the joint, and even using a hormone called relaxin-2 that might be able to reverse scar tissue that's already formed. So what's the big takeaway from all this? Well, while we have a really clear ladder of treatments for a stiff knee, the real future, the real hope, seems to lie in prevention. And the evidence is pointing to the idea that simple, common anti-inflammatory drugs could dramatically slash the risk. It leaves us with this pretty amazing question. Could the key to solving one of the biggest challenges in knee surgery already be sitting in our medicine cabinets?